All right. We're live. I will, I think we're gonna hold out on for about 5 minutes. So we'll start at 9:05 and then we can get started. So we'll just wait for people to start coming in. All right, I think we can get started now. So hello everyone, welcome back to my medical message. Thanks for joining today. Today we have Dr. Amina Farooq, and she is a radiologist resident, and she's here and she prepared a lovely presentation for us today. So welcome to our platform.
Thank you so much for having me. It's such a pleasure to be here. So my goal for this presentation is for you guys to really understand what a radiologist does. Oftentimes I walk out into the world, whether it's at the grocery store or, just going about and doing non-medical things. And people ask me, what are you doing? What are you studying? What are you training for? And I tell them, I'm training to become a radiologist. And their question is, who's that? What's that? So today's goal is to sort of demystify that for you, and also tell you a little bit about my journey and how I got to where I am today. So let's start. All right. So for me personally, I grew up in Atlanta, Georgia, and I did my undergrad at the University of Georgia, majored in biology and ecology. I stayed local for med school. I went to the Medical College of Georgia, which some of you might know is the oldest state med school in the country. And then I also stayed local in Atlanta, close to my family for my internship. And I got married during med school. So I moved closer to my husband's family in Long Island, New York, where I'm now a third-year radiology resident, a year and a half away from graduation, which is super exciting. So the first few slides here, I think are kind of interesting. And, some of you might be able to appreciate them at this stage. When you're a medical student, it's really hard to figure out what you want to do, right? And people sort of joke about it. They're like, well, do you like kids? What do you like to do in your free time? And all of these different things. So I found this graphic that someone made kind of funny. And if you follow it down, it's like, how are your grades? Well, your class hates you, but you don't like doing surgery. And if you're socially awkward, you kind of end up in radiology. It's, I think it's funny, but at the same time, these are stereotypes. And this next slide was actually done by a medical student talking about sort of what are the major stereotypes that medical students have of different doctors in subspecialties. So the bigger the word is, that means that most people think that way, or most medical students perceive that specialty to be composed of these characteristics. So I'm not going to go through all of them, but I'll point you over to radiology, which, people kind of say dark, antisocial, visual, boring, reclusive, lonely. I wouldn't describe myself as any of those. In fact, like I have a pretty robust social life. I love to go out. I love to spend time with my family, my husband, my friends. But again, these are just things that you'll hear, during med school, before med school, after that. And these are just generalizations and stereotypes. Sometimes they're funny, but you have to realize they don't represent everyone that's in that field. And so I just wanted to share a little bit about my family and my journey into medicine and the things that influenced me. So this is a picture of me and my husband at our wedding. This is my mom, my dad, my brother, and my three sisters. And within my immediate family, we've had 3 transplants. So my mom had a bone marrow transplant over 10 years ago. And my older sister, she was the reason my family moved here from abroad. She was born with a congenital heart defect, and she had to have surgery. And she was operated on by the father of heart transplant surgery, Dr. Norman Shumway at Stanford. And so, American medicine, surgery, all of the advances have saved 2 lives that are very close to my heart and in my family. But they've changed countless lives, right? It influenced me to go into medicine. It influenced my sister, my brother. All of us are in medicine, becoming physicians, and hopefully are going to have an impact on the future in a positive way. So this is just a little bit about my family and sort of the guiding influence that they've had. So I want to jump into some specifics about radiology. I think it's really sad that a lot of people don't know all the different things that you can do as a radiologist. And so one of my missions is to go around and tell you guys all the different things that we do, all the different people and different patient populations that we work with. And that's what this slide is for. So I've divided it sort of left to right. On the left side of the screen, these are subspecialties in radiology that are very interventional. So you work with patients, you work and do procedures. It's very interactive, very clinical. So breast radiology, interventional radiology, musculoskeletal and nuclear medicine. And if you are more of a person that just likes to read studies and interpret imaging and do protocoling, if you're interested in working with children, there's pediatric radiology, neuroradiology, body imaging, chest, and emergency radiology. So as you can see, it's such a diverse field. It's such a diverse specialty. We work with all age ranges. We work with a lot of advanced technology, and we do tons of procedures. Some of the most advanced procedures were actually developed by radiologists. So it's pretty incredible, the impact that we've had in medicine as a whole. And so this next slide is a term that a lot of radiologists will throw around as modality. They'll say, well, we're going to use this imaging modality for this procedure or to get to this diagnosis. And, when I was starting out, I just was like, why do they keep saying this word? What do they mean by modality? And what they mean is that in order to get to a diagnosis, you need to use a certain type of imaging to adequately get to the correct diagnosis. So if you use like a one-dimensional X-ray, that's a radiograph. If you use three-dimensional X-rays, that's called a CT scan. If you use magnetic imaging, that's an MRI. If you use fluoroscopy to do procedures, that's interventional radiology. If you're using radionuclides for imaging, that's nuclear medicine. And if you use the physics of sound to create images, that's ultrasound. So all of these are different modalities that we use practically on a daily basis as radiologists. And they help us to get to the diagnosis, which ultimately then leads to the correct treatment and appropriate treatment for the patient. All right, so when I sit down and someone puts an image in front of me, what is my thought process? What's my approach as a radiologist? And this is very, very simple. And for every study, within the first 10 seconds, 20 seconds, this is what I'm doing. This is how I'm orienting myself. So the first question I ask myself is, what modality am I looking at? Is this an ultrasound, a CT, an MRI, an X-ray? The next question is, how was this image acquired? So we're going to talk a little bit about imaging planes in a second, but in a hospital, right, like sometimes your patients can come down to the radiology department. Sometimes they're very sick. They're in the ICU, they're in the PACU or in the ED, and they can't physically come to the radiology department, maybe because they're hemodynamically unstable. And so in those instances, we're able to take the x-ray or take the ultrasound down to them and acquire the image that way. And that can influence how we interpret the image, whether or not you give contrast or don't give contrast, what phase of contrast do you image in. All of these things are going to impact how we interpret the study. And then the next thing, and the whole reason why you go to med school is so that you can interpret these images in the context of patient history and what their chief concern is. Why are they coming in? Do they have abdominal pain? Do they have a headache? Did they have trauma? So you're taking their entire clinical scenario and situation into account while interpreting. And then you have a search pattern. And this is going to be different for every single modality. And then also you're thinking about what are pertinent positives and pertinent negatives that are going to help us to come to a clinically sound diagnosis for the patient that's behind the image. So I mentioned in the previous slide that when we're acquiring an image, we acquire it in certain planes, right? And this is a slide, this is a picture that you guys will see a lot when you take anatomy. Maybe you've already seen it, but it's basically how the three different ways that you can chop up the body anatomically. So if you're going from front to back, that's the coronal plane. If you're going from side to side, left to right or right to left, that's the sagittal plane. And if you're going from head to toe, that's the axial plane. This is pretty standard anatomic planes and positioning. And we use these as our foundation when we're interpreting images. So the last thing before we jump into the second part of this presentation is descriptors. So as radiologists, we are communicating our findings from imaging to the referring clinician. So whether it's the ED doctor or the surgeon or the OBGYN or the family medicine doctor, we have to basically use words to describe what we're seeing in the imaging and talk about the anatomy, give a description of its severity, to communicate to them the urgency of the findings. So these are just a few examples. The heart is grossly enlarged, no active lung lesion, minor blunting to the left costophrenic angle, and writing things, dictating things in this way helps to communicate these findings in an efficient and effective manner that's clinically relevant to our referring doctors. So now we're going to get into the second part, which is my favorite part of the presentation. And it's talking about radiology cases. I'm going to go through a couple of normal examples, and then I'm going to give you examples with pathology. And hopefully that'll give you guys a good comparison. And we're going to go through the same process that I would go through sitting at in the hospital doing my work on a day-to-day basis. So you guys will really get to see how I approach radiology every day. So without further ado, the first case we have here is a chest x-ray. So this is modality, this is a radiograph. And it's a frontal image, so coronal plane. And we are just going to go through the search pattern. So I typically start and look at the lungs first. So make sure that they're both pretty clear. And then I look at the heart borders. I look at the diaphragm, below the diaphragm. Then I work my way up the spine, look at the clavicles and the scapula, work my way down the ribs, and then go back through the heart and lungs one more time just to make sure I didn't miss anything. And then the last thing I look at is the soft tissues on the side, just to make sure that I don't miss anything that could be indicative of some unsuspected pathology. So this is in comparison to our next case, which the modality here is an X-ray or radiograph. So of the chest, and the imaging plane is a frontal plane. Here we see a consolidation of the right middle lobe, And the history in this case was a patient with fever and chills. So putting this all together, the diagnosis that fits is a pneumonia. So that's the first example. We're going to switch modalities into CT. So this is a CT, a coronal plane, and just showing you some of the normal anatomy here. Here's the liver. This is the portal vein, the gallbladder. We have the stomach here, the spleen, the diaphragm, the bottom of the heart, bottom of the lungs, the ribs. Then we've got the small bowel, the large bowel, the mesentery, the bladder. We have the pelvic bones, the femur, musculature, and then subcutaneous fat. And this is a pretty normal CT. There's really no pathology that is notable here. And we're going to contrast that with this case. Again, same search pattern. So we have a CT coronal plane. And here, what immediately jumps out is a large, well-circumscribed, heterogeneous mass with enhancing internal components. The history in this case was a young person who was asymptomatic, and they got this scan. So this turned out to be a biopsy-proven liver hemangioma, which actually, if you know the imaging characteristics of a liver hemangioma, this goes very well with that. So this is a classic case. Next, we're going to switch modalities to an ultrasound. So here we have a sagittal view of the uterus. You have the bladder sitting in front of the uterus feeding into the vaginal canal. And this is pretty normal. I don't see any pathology that would be concerning here. We're going to contrast that to this ultrasound, which again is a sagittal view of the uterus on an ultrasound. We see a yolk sac. Here, the history was a missed period. And hopefully you guys can make the diagnosis that that is corresponds to an intrauterine pregnancy. So switching to our last modality, breast radiologists work with a specific type of X-ray called a mammogram. And this is used primarily to screen for breast cancer, but it can also detect other pathologies. So here's the skin of the breast. You have your nipple right here. This is the pectoralis muscle. And then this is just a little bit of fibroglandular tissue mixed in with fat in the breast. And this is a perfectly normal mammogram. I'm going to contrast that to this mammogram, which has again, mammogram. This is a craniocaudal imaging plane. I would describe this as a spiculated mass in the lower left breast. This patient had a family history, a strong family history of breast cancer, and this diagnosis ended up being a biopsy-proven breast cancer. So that's the end of my cases. And hopefully that gave you guys sort of a nice overview of all the different things that we do as radiologists. They just wanted to give you a sneak peek. I obviously didn't include things like pediatric cases or nuclear medicine. That stuff is kind of advanced, but I think that gave everyone a sufficient flavor of the variety of things that we do. And really, it's to show you that as radiologists, we're really acting as detectives. If you think about the evolution of medicine, it's pretty amazing. Like 100 years ago, we couldn't see inside the human body unless you did surgery or unless the patient was dead and you were doing an autopsy. And fast forward to the 21st century, and we can put a patient inside a CT scan 5 minutes later and non-invasively tell you exactly what the problem is, if there's a problem. So we use the information that we get from these images along with the clinical history to solve diagnostic mysteries. We play an absolutely fundamental role in preoperative evaluation of surgical candidates. We evaluate post-surgical complications through imaging. And I really think radiology is one of the most challenging specialties because there's so much to know. You have to know about every organ system, every pathology, all the different types of surgeries. And as medicine and surgery and the science and technology behind imaging continue to evolve, so do we as radiologists have to evolve our brain and our eye and retrain so we can see the things that help lead to the right diagnosis. So, I hope this presentation encouraged you guys to consider radiology in your future plans. I just want to put in a plug for social media. Feel free to reach out to me anytime, and also utilize social media as much as you can. It's such a powerful tool that I think COVID has brought to light in terms of interacting with different people in different specialties and really getting to know what they do and what they bring to the table in medicine is so important. And, I know a lot of people with these networking things ask for advice. And no matter what your stage is, whether you're a pre-med, a medical student, you're already in training, my advice is to continue networking as much as possible. You can never reach out to enough people, get enough information, learn about something different. It's going to be so valuable to you as you make your way through medicine and into whatever career path you choose. So I definitely cannot emphasize this enough. And the final thing I want to say is that you're going to have inevitably, no matter what specialty you choose, no matter what career path you choose, you're going to have people who are going to doubt you. And you're going to have people who are going to make you doubt yourself. But you have to have enough faith and you have to have a strong voice that's inside your head telling you that those voices don't matter. And your belief in yourself, that voice is so powerful. And don't let anybody's voice become stronger than your own in your journey through medicine. And with that said, I just want to thank you guys so much for your attention. I know it's late for people on the East Coast, but it's always a pleasure to do these. And thank you so much again for listening. So I'm going to drink water and I'm going to look at the chat box and start answering the questions here. All right. So I'll just start with the first one. So the first one is there a specific group of people that you see more patients in? I'm not sure if that's referring to a specific specialty within radiology. I'm going to assume that it is. And so, yes, there are certain subspecialties within radiology where you definitely interact and see more patients. And if you remember the pink slide I had up before, so interventional radiology deals a lot with patients, breast radiology, pediatrics, nuclear medicine, musculoskeletal. Those subspecialties tend to do a lot of procedures, so they have a lot of patient interaction, a lot of continuity of care. That's a little bit less so in other specialties like subspecialties of radiology like neuroradiology or body. Okay, this one's good. What inspired you to become a radiologist? How is COVID affecting your workplace? So, for me, I think I spoke about this earlier in the presentation. I've always kind of been fascinated by the technical and technological advancements, not only in medicine, but just like in society in general. I think all the stuff that's going on in Silicon Valley is very cool. And I just knew that in my career, like I wanted to be in a subspecialty that was very innovative, that was cutting edge, that was doing the latest thing and sort of advancing medicine as a whole. And when I was a medical student, I just found that radiology checked all of those boxes, and that is what inspired me to go into it. COVID affecting the workplace. I think COVID has kind of just been, it's, you know, got to wear masks now, which we didn't have to do before. Schedules. I think when you have more than one resident on a rotation, we stagger schedules so that we can continue to socially distance. But, I think we just follow protocols that pretty much everyone has to. And I don't think it's disrupted things to a degree that's affecting my education or training, which I think is really positive. All right. Next question is whether you have ever handled a case that x-rays could not diagnose. Yes, absolutely. We like almost every day. So one thing that people don't understand is that x-rays are kind of they're a screening tool. You can see big things there, you could see big pathology, but there is always like a CT scan, especially for the lungs, is going to be way more sensitive. It's going to pick up small findings like lung nodules that a chest x-ray can't. And if you are, if you have a fracture that you can't see on an x-ray, sometimes you can pick it up better on MRI. So the answer to that question is absolutely yes. It happens all the time that we see pathology on x-rays that, or we don't see on x-rays that we see better on other imaging. Okay, so what type of radiologist are you? What year of residency are you in? Isn't radiology one of the most popular fields to do in general? Do you work with animals too? Okay, so that was a lot of questions. So what type of radiologist? So I am training to go into interventional radiology. So I'm going to be doing a fellowship after next year. And I'm in my third year of radiology residency, my fourth year of residency in general, because we have to do an intern year. Isn't radiology one of the most popular fields? Yes and no. So I think yes, and that once people find out about it, they realize how amazing it is. But no, and that a lot of people don't really know about it, and about all of the different things that we do. So, it's kind of yes and no is the answer to that. Do you work with animals? No, we just work with humans. I have done basic science research with animals, but that was a while ago. All right. So what is the best part about being a radiologist? What do you think is the future of radiology and doctors in general? Yeah, so I think there's so many amazing things about radiology. I can't, I could talk all day about this, but I think it's again a very engaging field. It's very fun. You're never bored. There's always something new or interesting coming down the line. You can share interesting cases with your colleagues. And I think the future of radiology is actually very bright. I think radiology is going to be driving a lot of major changes related to the use of artificial intelligence and machine learning in the future. And I think that there's people who say that, oh, AI or machine learning is going to replace radiology, which we already have artificial intelligence in radiology and I use it, and it's wrong a lot of the time. So I think there is definitely going to be a major role for radiologists and physicians, of course, in the future. And I think that sort of answers the next question too, which was, how important are radiologists to the world? I think they're absolutely critical. I think that in this day and age, we are trying to not cause harm to patients. We want to not do unnecessary surgeries, not cause undesired complications. And the way to do that is non-invasive imaging, which is what radiologists do day in and day out. Okay, what is the difference between the residency training of a radiologist and that of other specialties? So radiology training is one of the longer, it's one of the longer residencies compared to like internal medicine, which is like 3 years, family medicine, 3 years. We are a 5-year residency. So you do a year-long internship and then 4 years of radiology. And then some people go on to do 1 or 2 years of fellowship. So that can pretty much add up to like 6 or 7 years of training after med school. I already answered, do you think AI will replace radiologists in the future? The answer is no. And I will say that one of my favorite quotes is by the president of the American College of Radiology, which is that AI will not replace radiologists in the future. Radiologists who do not use artificial intelligence will be replaced by radiologists who do use AI. So we're going to be incorporating it, but it's not going to replace what we do. Okay, next question is, how do you know what scan to use, like MRI, CT, or PET? What made you choose radiology over other fields? I think I answered that. So in terms of what scan to use, it's really based on indication. So for example, if a patient's coming in for breast cancer screening, we know that the right imaging is to do a mammogram. If a patient we're concerned about cancer staging, we use a PET scan. If we're not sure, but they're having vague generalized abdominal pain, they're coming in for the first time, you can do a CT. So it really just depends on the indication and why we're getting the scan. Let's see, how much does it cost to perform scans? That's a very good question. So it varies. It really varies across institutions. We use something called RVUs, and these are sort of help to quantify like the worth of like an MRI or CT and a PET. And it's not just the fee for the radiologist who's interpreting it, but it's also the tech who's scanning the patient. It's also the machine, because these machines are very expensive. So all of those things factor into how much it costs. It can vary by institution or where you go. But those are the things that we consider when you get one of these scans done. Do you work closely with other doctors in a different specialty? Absolutely. We work with all specialists, general surgeons, transplant surgeons, primary care doctors, urologists, pathologists, oncologists, every single specialty we interact with. All right, what are your thoughts on interventional radiology? So since that's a field that I'm planning to go into, I love it. I think it's really exciting that you not only get to interpret the images and make findings, but you also get to intervene and do procedures that can often save people's lives. So yes, my thoughts are, I think it's a fantastic field. I think it's cutting edge, and I think it's going to be the future minimally invasive surgery, minimally invasive procedures. What does a day on the job generally look like? What are the greatest obstacles you have with procedures? What are the factors that affect each surgery? So a day on the job for general diagnostic radiology, I usually come in at around 7:30 in the morning. I protocol any cases that haven't been protocoled for a fluoroscopy. And then depending on what rotation I'm on, I read from a list. So this week I'm on neuroradiology, and so I'll read from a neuroradiology list: CT heads, MRI of the head, MRI of the spine, CT of the spine, cranial ultrasounds. And then in the afternoon, I'll go over it with an attending. And then we repeat the process basically every single day. And then if you're on interventional radiology, it's a mix. You're doing procedures, you're consulting patients, you're consenting patients, you're reading emergent studies, you're closing the loop on cases with other clinicians. So there's a lot of stuff that goes into your day on that. So I think I already answered this. How did you decide to become a radiologist, and how has the field changed because of COVID? Again, I think most hospitals are just instituting the normal like ways to protect patients, like wearing masks, social distancing, cutting out waiting rooms and things like that, and cleaning the inside of the CT scanner, MRI scanner, so that patients have a decreased risk of exposure. All right. So, a fellow Georgia. As someone who also lives in Georgia, what high school and college advice would you give? Yeah, so I mean, I don't know if it's specifically in Georgia, but I think it sort of applies no matter where you go. But I think you should have an open mind. I think it's really important to keep an open mind about how your trajectory is going to work out, right? Like, I think people, when we're young, we get very fixated on our trajectory. Like, I have to graduate from high school, graduate from college, get into med school, residency, do all of these things. It might not work out in a very straightforward fashion for you. And so don't get discouraged by that. Let it be encouragement for you that, okay, I didn't make it this year. Things didn't work out this year. What can I do differently? How can I improve myself? And how am I going to let this setback be a stepping stone forward for me? And I think if you sort of have that mindset, all of the inevitable challenges that you're going to face, you'll just be able to deal with them with a lot more grace. All right. Okay, a lot of these questions are the same, so I'm just going to skip a couple of them. This one's a good one. Do you perform tasks only related to your specialty, or do you do other general physician work? I would say just related to my specialty. Once you get to this point of your training, it's kind of hard to go back to things that you learn for primary care. So, it's mostly what you're training in residency for. Let's see, what major and classes do you recommend taking in college? So I think you can major in whatever you want, but I think major in whatever interests you. If it's math, if it's science, if it's the arts, that's fine. But realize that the prerequisites, the pre-med prerequisites are really important because they're going to help you with the MCAT, and they're sort of going to set the foundation for what you learn in the didactic portion of med school. So major in whatever you want, just pay attention and, do your due diligence with the prerequisite classes because they're there for a reason. Okay. So what new advancements and technologies have been developed in the past few years that have improved how you do your job? Oh, this is a great question. Tons of new technologies. I'll talk about one related to interventional radiology because that's what I'm going into. So, many years ago, to treat liver cancer, they would, they would do surgery, they would do liver transplants, they would do liver hepatic resections, chemotherapy, radiation. One of the latest procedures is a Y90. And what the Y90 does is it basically takes radioactive particles and delivers them right to where the cancer is in the liver. So you can spare liver function. So the patient doesn't have to have a transplant. They don't have to get surgery, but they can still treat the cancer and sort of, improve their prognosis or how long they're going to live or survive from that. So that's one of many examples of new advancements in technologies and how they're improving medicine. All right, so this is a cool one. Radiology is a specialty which requires a lot of communication. How do you communicate with other specialties in a flawless manner? So I think this is a great question. At the end of the day, it really boils down to individual style, but I would say they're sort of the basic tenets are being available. So if someone's coming in to talk to you about a study, don't just brush them off and say, I don't have time for you. Make yourself available, be affable, be kind. Don't, have a chip on your shoulder or be like, how come you don't know this? Medicine is just, there's so much to know, there's no one doctor that's going to know everything. So being kind, being understanding, and being available, and then also communicating effectively. So, one of the things that we do is when we call for critical findings, like a stroke or something, I always ask, can you just repeat back the findings that I just told you? And that ensures that they've heard what I said. They know that the patient has a bleed, they have a stroke or whatnot, and they're aware, and now they're going to be able to appropriately manage the patient from their standpoint. So that's sort of my tenets behind communicating effectively. What forms of imaging work for what specific diseases or treatments? That is a very long question with a very long answer. So I'm just going to say that you'll have to explore radiology and do a rotation to learn the answer to that question. Okay, so how is work-life balance in radiology? How do you see radiology changing as new technologies are introduced? Work-life balance, amazing. Totally an underrated part of radiology. And I think something that a lot of people don't know about. We have, it's great. Lots of people have families and kids during residency and in training. And I think it's a fantastic field to continue work-life balance through a lifetime. And we talked about how radiology changed, some of the technologies that we've introduced. I also talked about treating a patient in a clinical setting with Y90. What is the most rewarding part about being a radiologist? I think it's just the fact that in a day, you can interpret like more so than 100, over 100 images for 100 different patients or over 100. And you've managed to make a difference in their patient care, which not a lot of specialties can say that. How many specialties can say, I changed management of like 100 people's lives? Not a lot. So, are you able to maintain a relationship with your patients as a radiologist? Absolutely. We talked about that. Let's see. Are there specific specializations or certifications that one would need to specialize in a specific type of radiology? Yes. If you want to go into a very specific area, then you would do a fellowship. Examples are interventional, breast, pediatrics, all the ones that I listed earlier. Okay, so what modality of radiology do you most prefer and why? The This one's interesting. I love all of them. I think everyone offers a unique perspective, and I really like ultrasound. I think it's very cool because in third world countries where people oftentimes don't have CT scanners or MRIs, you can still get so much information from a portable ultrasound, and it's easy to carry around. Okay, and what advice do you have for the SAT, ACT, and MCAT? I think general test taking advice. So there's this concept that people don't really, I don't know if a lot of people are aware of it, but it's the idea behind spaced repetition. So for all of these tests, they're going to test you on like a ton of different things, right? It's a large volume of information, and you're going to have to take it in one sitting. So, how do you mentally prepare your brain for that? Is you take chunks of information and then you just keep repeating them. So doing question banks, repeating question banks again and again and again. And how do you learn? Do you learn by doing questions and reading the explanations, or do you learn by listening to videos or audio resources? I know Khan Academy has a ton of really great resources. There's also just so many great videos on YouTube that you guys can use if you're more of an audio visual type of person. But for me, it boiled down to doing tons of questions, tons of practice tests, and then also just reading. So, that's my advice, is figure out your learning style and then just practice. Okay. And I think that answers all the questions. So,
Yep. It seems like that's all the questions that they have. Thank you so much, Dr. Farooq, for joining us on our platform today. This was a really informational presentation. I learned a lot about radiology today that I didn't have any idea about before. So thank you so much for joining us today. And for all of our viewers, I posted the link to the Google Forms in the chat, and it'll close at 10:30 p.m. EST. So thanks again for joining us, Dr. Farooq.
perfect. Thank you again for